Carcinoma breast is one of the most common carcinoma in females and is one of the second most common carcinoma causing mortality in females. Now, what is the etiopathophysiciology of this condition, carcinoma of breast? Coming to risk factors, we have modifiable and non-modifiable risk factors. The non-modifiable risk factors are demographic features like female gender. Females are 100 times more risk, have 100 times more risk to develop breast carcinoma compared to males. It also increased estrogen exposure in females where they have, if they have nulliparity or early menarche, late menopause, it's also a risk factor for developing. People with increasing in age, the patient have increased risk to develop carcinoma of breast. From 35 to 75 years of age, there is increased risk of developing carcinoma of breast. White race is more prone for developing breast carcinoma than Japanese and other people. If the patient has family history of carcinoma of breast, the patient have 1.5 to 3x, means 1.5 to 3 times more risk to develop breast carcinoma compared to other populations. The syndromes, genetic syndromes like Cowden syndrome, ataxia telangiectasia, and Leigh-Fromage syndrome has been associated with breast carcinoma. The patient has BRCA1 and 2 mutation, BRCA1 present on chromosome 17, BRCA2 present on chromosome 13. If the patient has these 2 mutations, they have increased risk for developing carcinoma of breast. Along with that, they have increased risk for ovarian tumor. Cowden syndrome is associated with P10 mutation, where the around 30 to 50% of patients by the age of 50 years will develop carcinoma of breast. Along with carcinoma of breast, they can develop oral papilloma, bilateral breast carcinoma, hemangioma, thyroid carcinoma, and lipoma. This is about Cowden syndrome. Then we have ataxia telangiectasia, having increased risk for breast carcinoma. Along with that, the patient will have the hemangiomas. Leigh-Fromage syndrome, the patient has P53 mutations, the guardian of cell, where 90% of them develop carcinoma of breast by 50 years of age. Along with this, they have other multiple neoplasms because of loss of function of P53 gene. These are about non-modifiable risk factors. Coming to modifiable risk factors, they are breastfeeding. If the patient has increased duration of breastfeeding, then it has been associated with reduced risk of carcinoma of breast. The postmenopausal HRT hormone replacement therapy, where we give estrogen and progesterone combination, is been associated with increased risk of breast carcinoma. The diet, if the female consumes more and more saturated fats and reduced consumption of vitamin C, folate, and beta carotene, food containing these 3 vitamins, the patient will have increased risk of breast carcinoma. In postmenopausal obese patients, we see increased risk for developing carcinoma of breast. Consumption of alcohol and smoking are other modifiable risk factors of breast carcinoma. And also radiation exposure in case of Hodgkin's lymphoma less than 15 years of age is also a risk factor for developing carcinoma of breast. These are about the risk factors. Let's go on to see the pathology of carcinoma of breast. Under pathology, we have, before that, let's briefly review the anatomy, the required anatomy. We have lactiferous duct. These are the lactiferous duct which drain the blood. Which drain the milk that is coming from terminal duct and lobule unit, TDLU, where the terminal duct and lobule unit is formed by the acini which secrete the milk and the terminal duct. This forms terminal duct lobule unit. From here we see origin of the lobular carcinoma. From lactiferous duct we see the origin of ductal carcinoma. So we'll see. Also we have these related terms, multicentric and multifocal. We'll come to it afterwards. Under pathology, we have, based on growth pattern and cytological features of cell, the WHO classification of breast carcinoma. We have non-invasive epithelial tumors and invasive epithelial tumors. Under non-invasive epithelial tumors, the one which is coming under breast carcinoma is ductal carcinoma in situ. Under invasive epithelial tumors, we have invasive ductal carcinoma and invasive lobular carcinoma. Along with these 2 categories, that is non-invasive epithelial and invasive epithelial tumors, we have tumors which are arising from connective tissue and stroma. Those are mesenchymal tumors like filled tumors, etc. So under non-invasive epithelial tumors, we have ductal carcinoma in situ, mainly, which is considered as carcinoma of breast. Also, we have lobular carcinoma in situ, which now has been considered as benign disease with risk for malignancy. The non-invasive epithelial tumors are group of tumors where the cellular atypia will be there in the tumor cells, but the tumor cells doesn't invade the epithelial basement membrane. So these are precursor lesions for invasive carcinoma of breast. Under this, first we are discussing ductal carcinoma in situ, which originates from ductal epithelial cells. These ductal epithelial cells. These cells have impaired N to C ratio, nucleus to cytoplasm ratio, and cellular atypia, mitotic bodies, and all. More than 50% of untreated patients of ductal carcinoma in situ will develop invasive ductal carcinoma. Now, this ductal carcinoma in situ, we see the atypical cells filling the duct without breaching the epithelium. This is the normal anatomy, normal histological features of breast. This is the invasive one, the ductal carcinoma in situ. We have under ductal carcinoma in situ, we have two types, that is low grade type and high grade type. Low grade or comedome type, where the tumor cells fill the terminal ductal lobular unit. After originating from ductal epithelium, they invade terminal ductal lobular unit and they fill the terminal ductal lobular unit. And also in these tumors, comedome type of tumors, there can be central necrosis seen, which is called as comedome necrosis. We have non-comedome type or low-grade tumors, which are solid, papillary, and cribriform in types. Clinically, these patients with ductal carcinoma in situ can present with nipple discharge or lump in the breast, or they can present with Paget's disease of nipple, or it can be incidental finding on biopsy, which we do for other. If we do biopsy for other condition, we may incidentally find ductal carcinoma in situ, or on mammography screening, we can pick up ductal carcinoma in situ because of calcification and non-proliferative mass. Now, how to manage this condition? Ductal carcinoma in situ. Investigation, we perform USG-guided FNC and mammography. Under treatment management, we have breast conservative surgery followed by radiotherapy, or we can perform simple mastectomy with lymph node biopsy. And if lymph nodes are involved on biopsy, we should remove them. So in premenopausal women, we can, after doing surgery, we can give tamoxifen, which is a SERM, selective estrogen receptor modulation, and post-menopausal women, we can give letrozole, which is an aromatase inhibitor. This is about ductal carcinoma in situ, which is considered as part of carcinoma breast, non-invasive epithelial tumor. Next, we have lobular carcinoma in situ, which originates from terminal duct lobular unit. We saw that ductal carcinoma in situ arising from epithelial lactiferous duct epithelial cells. The terminal duct lobular unit give rise to lobular carcinoma. Lobular carcinoma in situ. Here, the lobular carcinoma in situ are 50% bilateral. Around 30% of them will progress on to develop invasive lobular carcinoma. Around 65% of them will progress to develop invasive ductal carcinoma. So these cells of lobular carcinoma in situ are loosely attached with one another. They are not cohesive, meaning one cell doesn't attach with another cells. They are present as discrete cells because of loss of equidherin function, which is responsible for cell and cell cementing, cell to cell cementing. So due to that, we will see discrete discohesive cells in lobular carcinoma in situ. We have two types of lobular carcinoma of in situ, that is classical type and pleomorphic type. In classical type, we have epithelial cells that are discohesive, epithelial cells, discrete cells, which are present within the filling the terminal ductal lobular unit. These cells have the big nucleus with scanty pale cytoplasm. Under pleomorphic type, there will be comedonecrosis and calcification. See on top of these findings. The treatment of classical type of lobular carcinoma in situ is nothing. We'll do close follow-up. And then if the patient develops carcinoma, we'll treat accordingly. If the patient develops invasive carcinoma, we'll treat accordingly. If the patient has pleomorphic carcinoma in situ, the treatment is similar to ductal carcinoma in situ. So in lobular carcinoma in situ, it is important to note that the patient usually doesn't have any clinical symptoms. It is usually picked up when we do surgery for other conditions of breast, or if we do biopsy for other conditions of breast. I already told lobular carcinoma in situ is now considered as benign disease, which increased risk for developing carcinoma. It doesn't come under the WHO classification for carcinoma of breast, whereas this ductal carcinoma in situ is a part of breast carcinoma. Next, we are proceeding on to discuss about invasive epithelial tumors. Invasive epithelial tumors are divided into invasive ductal carcinoma and invasive lobular carcinoma. Under invasive ductal carcinoma, we again have subtypes, that is invasive ductal carcinoma with no special type, which is the commonest carcinoma that we see in breast. 70 to 80% of breast carcinoma is due to invasive ductal carcinoma with no special type. The remaining special types are tubular type, which is around 2%. It has good progress where we see tubular structures, the tubular gland-like structure, architecture of the cells. Then we have colloid type in tube, another 2%, which is mucinous type, where the cells secrete mucin. There will be gelatin-rich secretions inside the cells. With the cell secrete, we'll see in the lesion. There is 5% can develop medullary tumor, which has consistency similar to that of the brain, which is soft tissue. The other special types are rare forms: invasive cribriform type, invasive papillomatous type, adenocystic type. So this is about invasive ductal carcinoma. The invasive ductal carcinoma with no special type, which we see in 70 to 80% of patients, most common breast carcinoma. Here, the tumor cells will stimulate intense desmoplastic reaction in the surrounding tissue, causing excessive fibrosis. So this tumor will be hard, has irregular margin with intense desmoplastic reaction with extensive fibrosis. So while we cutting the lesion while performing gross examination, pathological examination, there will be grating sensation while cutting through this lesion. So it usually has perineural and perivascular invasion, the invasive ductal carcinoma, no special type. Next, invasive lobular carcinoma contributes for around 10% of carcinoma that we see in 10% of breast carcinomas. This invasive lobular carcinoma is usually multicentric and multifocal. Multicentric means the lesion, the breast carcinoma, is present on one or more than one quadrants of breast. Multifocal lesions means inside one quadrant of breast, we see more than one lesions. This is about multicentric and multifocal tumors, which are common in invasive lobular carcinoma. Invasive lobular carcinoma, we saw in the lobular carcinoma in situ, these cells are not cohesive. So they are present as discrete cells because of loss of E-cadherin function. So these cells will be present as single file type discrete cells will be present in between the normal breast tissue. So there will be no distinct mass formed due to this invasive ductal carcinoma. Rather, we see diffuse thickening of the breast in the involved lesion, in the involved site. So the clinical manifestations, we have the nipple retraction and skin changes seen in invasive lobular carcinoma is less obvious compared to that of invasive ductal carcinoma. So since it doesn't have distinct mass and no mammographic findings, usually the diagnosis of invasive lobular carcinoma is delayed and it is difficult to diagnose invasive lobular carcinoma. Then we have Paget disease of nipple. What is Paget disease of nipple? Paget's disease of nipple is the condition associated with invasive ductal carcinoma and ductal carcinoma in situ. It is a rare condition seen in around 1 to 4.3% of breast carcinoma patients, where the patient will have pigmented erythematous lesion, which has irregular border. And along with this lesion, the patient will have intense itching and pain. Due to itching, the patient may develop secondarily ulceration, and there, with the progression of disease, there can be destruction of nipple and areola complex. Investigation is we do punch biopsy from this lesion. Management is surgical treatment, that is modified radical mastectomy. This is about the Paget's disease of nipple, which is an associated finding that we see in invasive ductal carcinoma and ductal carcinoma in situ. Now, why this Paget's disease of nipple occurs? The Paget's cells, which are the malignant glandular epithelial cells, hyperchromatic nuclei, they invade the epidermis. You can see here, these malignant cells invading the epidermis. The invasion of malignant glandular epithelial cells to the epidermis is the cause for Paget's disease of nipple. So these cells have characteristically hyperchromatic nuclei with abundant pale cytoplasm. You can see here abundant pale cytoplasm, and also they'll have mucin inside the cell. This is about the Paget's disease of nipple, which is the associated finding in 1 to 4.3% case of breast carcinoma. So this is about the pathophysiology of carcinoma breast. To summarize, the risk factors, we have non-modifiable and modifiable risk factors. The non-modifiable risk factors are female gender, age between 35 to 70 years of age, and white race, and then family history, genetic mutations like BRCA1 and 2, and P53 mutation in Leaf-Romanes syndrome, P10 mutations in Cowden syndrome, and the patient having ataxia telangiectasis has increased risk for developing breast carcinoma. The modifiable risk factors are the postmenopausal female taking hormone replacement therapy is a risk factor for developing breast carcinoma. If the patient has increased duration of breastfeeding, it has been associated with decreased risk of breast carcinoma. If the patient intake more and more saturated fats and there is reduced intake of vitamin C, folate, and beta carotene, there will be increased risk of breast carcinoma. The postmenopausal obese females have increased risk for breast carcinoma. The alcohol and smoking is one of the modified risk factors for breast carcinoma. We have radiation exposure in Hodgkin's lymphoma less than 15 years of age is one of the risk factors for breast carcinoma. Under pathology, we saw we have non-invasive epithelial tumors, in that mainly ductal carcinoma in situ. And then we have invasive epithelial tumors like invasive ductal carcinoma and invasive lobular carcinoma. Ductal carcinoma in situ has two types: comedome, high-grade comedome type, and non-comedome type. The patient presents with nipple discharge or mass. Paget's disease of nipple, incidental, it can be incidental finding. Usually, mammography findings, we can see calcification and non-palpable mass. Management is breast conservative surgery with radiotherapy or simple mastectomy with lymph node biopsy and if involved excision. In postmenopausal, premenopausal females after surgery, we give tamoxifen. Postmenopausal females after surgery, we give letrozole. The lobular carcinoma in situ, we have classical type and pleomorphic type. Classical type, we only keep the patient on close follow-up. In pleomorphic type, the management is similar to the ductal carcinoma in situ. We have the invasive ductal carcinoma under invasive breast cancer. The most common type is invasive ductal carcinoma with no special type, which contributes for 70 to 80% of breast carcinomas. It has severe intense desmoplastic reaction causing excessive fibrosis. Other special types are tubular type, colloid type, medullary type, invasive cribriform type, invasive papillomatous type, and adenocystic type. These are the types of invasive ductal carcinoma. We have invasive medullary carcinoma where we see discohesive single file of cells due to loss of ecadin gene, and it is characterized by diffuse thickening. The patient doesn't present clinically with distinct mass, so it has less obvious nipple distraction and skin changes associated with that. The Paget's disease of nipple associated with invasive ductal carcinoma and carcinoma in situ, where we see pigmented erythematous lesion with irregular border. The patient will have intense itching and pain, and the patient can have ulceration with destruction of nipple and areola complex. It's due to epidermal invasion, epidermis invasion by Paget cells, which are malignant glandular epithelial cells. Next, with clinical manifestations seen in breast carcinoma patients, we have symptoms. The most common symptom with which the patient present is lump in the breast. Over 60% of lump in the breast are present in upper and outer quadrant because most of the breast tissue is found in this region. You can see the lump in the breast, the patient having lump in the breast. Next, other symptoms are the patient can present with bloody nipples discharge if there is involvement of lactiferous duct. and the patient presents with pain in later stages due to perineural invasion. Around 5% of patients presents with the features of distant metastasis, that is bony pain, pathological fracture or paraplegia due to spread to vertebra, mainly lumbar vertebra. The signs that we see in breast carcinoma is skin signs. We have nipple elevation or retraction, which is due to the involvement of lactiferous duct by the invasion of tumor cells into the lactiferous duct and surrounding fibrosis around the lactiferous duct, causing elevation and retraction of nipple. And nipple may be destroyed in case of Paget's disease of nipple. The patient can have dimpling in the skin due to infiltration of ligament of Cooper by the malignant cells. The patient can have PUD orange appearance due to invasion of malignant cells to the subdermal lymphatics. The invasion of subdermal lymphatics will cause blockade of the subdermal lymphatics and accumulation of the fluid, causing PUD orange appearance. The patient can also have multiple nodules in the breast. Here you can see the patient having multiple nodules in the breast, and in the chest wall the patient may have. This is called cancer en curace. And then the patient can have, here you can see the image of retracted nipple. So the skin findings are retracted and elevated nipple, dimpling of skin, PUD orange appearance, and multiple nodules, satellite nodules. And then the patient can have ulceration and fungation if there is infiltration of skin by the tumor tissue. The lump that we see in the breast is hard. Usually it is hard, and it can be soft or firm if the patient has medullary type of invasive ductal carcinoma, which we discussed. And the tumor, the lump has irregular margin on palpation. The lump can be fixed to the breast tissue. The lump is usually fixed to the breast tissue, and in the later stages, it can have deeper invasion into the pectoralis major muscle, serratus anterior muscle, and into the chest wall. So the invasion to pectoralis major muscle can be tested by asking the patient to contract the muscle by keeping the hand on waist and asking the patient to press firmly, keeping the hand on waist. So by this, if the lump get fixed to the muscle, meaning when the patient perform this maneuver, if we are unable to move this lump, then it suggests that the lump is fixed to pectoralis major muscle. The lump may be fixed to serratus anterior muscle, which can be tested by telling the patient to push wall without flexing the elbow. The lump may be fixed to chest wall, that is ribs and intercostal muscles in the later phase. This can be tested by asking the patient to lean forward. By asking the patient to lean forward, if the breast tissue doesn't fall forward, then it suggests chest wall invasion. So this is about the signs that we see in case of breast carcinoma. Due to spread of the tumor, due to the lymphatic spread, there will be lymph node enlargement. That is axillary in 75% of cases and internal mammary lymph nodes, not in 75% of cases. The 75% of lymph nodes, the lymphatic drainage of breast tissue, the 75% of it is drained by axillary group of lymph nodes. We have anterior group, central group, the posterior group, lateral group, and apical group. The anterior and central group of axillary lymph nodes are usually involved in breast carcinoma. The posterior and lateral groups are rarely involved. If these are involved, finally the apical group will be involved. Secondary to involvement of axillary group of lymph nodes, there can be involvement of supraclavicular group of lymph nodes and their enlargement. And also, in some patients, there can be involvement of internal mammary lymph nodes. Further, from internal mammary lymph nodes, the tumor can spread to mediastinal group of lymph nodes. The interpectoral group of lymph nodes, which are called as Roter's nodes, which are present between pectoralis major and minor muscles, can be involved. Subdermal lymphatics are responsible for spread of tumor from one breast tissue to opposite breast tissue. So these lymph nodes, after being enlarged, they can compress upon axillary vein. causing venous edema in the upper limb, wherein the patient presents with acute excruciating pain along the distribution of nerves. Also, the tumor can infiltrate the nerves, brachial plexus nerves. Most commonly, it involves the median nerve and ulnar nerve, causing the pain along the distribution of nerve. This about the lymphatic spread. We can have hematogenous spread of breast carcinoma. Most commonly, is it as bony metastasis in 70% of cases. The metastasis seen is the most common kind of metastasis, where usually it involves lumbar vertebra due to the spread of tumor cells from the breast tissue through valvulus Watson plexus to the lumbar vertebra. So this secondary tumor in the lumbar vertebra can compress upon spinal cord, causing paraplegia, that is flaccidity in the both lower limb, or it may involve the bony metastasis can be to femur or ribs. The secondary involvement of bone produces this lesion usually is osteolytic, and this osteolytic lesions may cause pathological fractures in this patient. So the patient can present with painful non-mobile swelling in the bones. So hematogenous spread after bony spread, we have spread to liver, where the patient can present with jaundice, hepatomegaly and all. The patient can have spread to pulmonary system, the lungs, where the patient will have cannonball secondaries and pleural effusion. And also, the patient can have transcoelomic spread, the spread through mediastinal lymph nodes, where it is this transcoelomic spread is responsible for spread of breast carcinoma to liver, peritoneum, and to the ovary. That is, the secondary spread, transcoelomic spread of tumors from breast to ovary is called Krukenberg secondaries. Nowadays, the most common accepted theory are hematogenous and lymphatic spread than transcoelomic spread for this Krukenberg tumor. So this is about the clinical manifestation seen in breast carcinoma. The symptoms we have most commonly lump. The patient can present with bloody nipple discharge, pain, or 5% of them present with metastatic disease, that is bony pains, pathological fracture, and paraplegia. The signs we have skin signs like nipple can be elevated, retracted, and it can be destroyed if the patient has Passage disease. There can be dimpling in the nipple. There can be dimpling of the skin due to infiltration of ligament of Cooper. The patient can have pudgy orange appearance due to infiltration of subdermal lymphatics. The patient can have multiple nodules, ulceration, and fungation of skin. The lump is hard usually. It has irregular margin. It is fixed. It is fixed to surrounding breast tissue, and in the later stage, it can have deeper invasion to involve pectoralis major muscle, serratus anterior muscle, and chest wall. The patient can have spread to lymphatic spread to axillary group of lymph nodes, internal mammary lymph nodes, rotors lymph nodes, which are interpectoral group of lymph nodes, and through subdermal lymphatics, the carcinoma can spread from one breast tissue, the one breast to the opposite breast. We have most commonly hematogenous spread to the bones. Most commonly, it involves lumbar vertebra. The patient may present with pathological fracture and painful non-mobile swelling. The patient can have hematogenous spread to lungs, liver, and also to the brain, causing increased acidity and coning. The patient can have transcoelomic spread to ovary, peritoneum, and liver. This is about the clinical manifestation seen in breast carcinoma. Under investigation, the gold standard for assessment of any breast lump is triple assessment, where we perform clinical examination, radiological examination, and biopsy of the lesion. Coming to radiological examination that we do in breast carcinoma, we have less than 40 years of age, we perform USG of breast, ultrasound of breast. In more than 40 years of age, we perform mammography, because in less than 40 years of age, small lesions can be masked by the fat. So to prevent that, we do USG in less than 40 years of age. We prefer mammography in more than 40 years of age. So the USG, we have in benign lesions, we'll see the lesions are wider than taller, and we'll see macro calcifications on USG. If the patient has malignant disease, the lesion will be taller than wider, and the patient will have microcalcification, which will be noticed on USG. And also, Doing ultrasound help us to know lymph node status and lump size. We perform mammography, which is low energy X-ray. Can be screening and diagnostic mammography. Screening mammography is usually done in more than 40 years of females more than 40 years of age, and also in females more than 30 years of age if they have family history of breast carcinoma. The diagnostic mammography will do if the patient to know whether the patient has multicentric and multifocal lesions. This is about mammography and USG. Next, we'll discuss about the biopsy that we do in breast carcinoma patients. FNSC, fine needle aspiration cytology, is not done nowadays because it can't differentiate between in situ carcinoma and invasive carcinoma, and also we can't do immunohistochemistry while performing FNSC. So, incisional biopsy, the core needle biopsy or true cut biopsy, is the investigation of choice in breast carcinoma, where we use 15 gauge needle and we take the chunk of tissue and we perform histopathological examination, and also we can do immunohistopathological study. We'll do punch biopsy, as I already mentioned, in Paget's disease of nipple. The vacuum assisted biopsies can help us to take more tissue while performing biopsy than compared to true cut biopsy. The immunohistochemical examination, we have ER positive. By this we can identify whether the tumor is ER positive, that is estrogen receptor positive, or progesterone receptor positive, which help us to decide whether to give the hormonal therapy to the patient or not. And also we can do immunohistochemical study of HER2/neu receptor, which is a transmembranal tyrosine kinase receptor. Seen in 50% of cases, the HER2/neu receptors are increased in 50% of breast carcinoma. They are excessively expressed. HER2/neu and Ki67 are markers of cellular proliferation. And usually HER2/neu will be positive in ER negative and high grade tumor, and they have bad prognosis. Ki67 is a nuclear protein which is a marker of cellular proliferation. This is about the incisional biopsy, the immunohistochemistry study. The excisional biopsy is a gold standard method, but we don't usually perform this. So this is about the investigation, that is radiology and biopsy. For detecting metastasis, we can perform chest X-rays to look out for metastatic cannonball secondaries in the lung. We can perform abdominal USG to look for secondaries in the peritoneum or liver. The better than these two investigation is contrast and CT to look for metastatic spread. We do bone scan to look for secondaries in bone. PET CT scan is only done in locally advanced breast carcinoma and inflammatory breast carcinoma. Inflammatory breast carcinoma is a kind of carcinoma seen in pregnancy and lactating women. It's a rapidly progressive carcinoma. It's a subtype of locally advanced breast carcinoma. So these patients have poor prognosis. The locally advanced breast carcinoma, we'll discuss what is it when we are discussing treatment. About the investigation that we perform in breast carcinoma. Let's going on to staging in breast carcinoma. TNM staging, we have T1 disease where the lesion is less than 2 centimeters size. We have T2 disease where the breast lesion is between 2 to 5 centimeters size. T3 lesions are more than 5 centimeters size. T4 lesions is divided into T4A, B, and C and D. C4A lesions have chest wall involvement. Chest wall involvement meaning involvement of serratus anterior muscle, ribs, and the chest wall muscles like intercostal muscles and all. Please note the involvement of pectoralis major muscle is not considered as chest wall involvement. This is T4A disease. T4B disease is involvement of skin with ulceration, QD orange appearance, or satellite nodules. Dimpling and puckering is not considered as skin involvement. That is C4B disease. The disease is called as C4C. T4C, if the patient has both chest wall involvement and skin involvement. It is called as C4D if the patient has inflammatory disease of breast. So inflammatory carcinoma, which I discussed previously. So this is about the tumor staging. The nodal staging, we have N0, where there is no nodal involvement. N1, if the patient has ipsilateral axillary group of lymph nodes involved and the lymph nodes are mobile. It is called as N2 disease if the patient has ipsilateral axillary lymph node which are involved, enlarged and fixed. It is N2A. N2B is the involvement of internal mammary group of lymph nodes without the involvement of axillary group of lymph nodes. The N3A disease is involvement of ipsilateral infraclavicular group of lymph nodes. N3B is involvement of both internal mammary group of lymph nodes and axillary group of lymph nodes. Please note that 2B and 3B are related to intermammary lymph nodes. And also N3C is involvement of ipsilateral supraclavicular group of lymph nodes. This is about the nodal staging. M staging metastasis, we have M1 if the patient has distant metastasis, M0 if the patient doesn't have distant metastasis. So based on the staging, we treat the patient. Under treatment, we divide the patient into 3 groups. That is early breast carcinoma, locally advanced breast carcinoma, and metastatic breast carcinoma. Under early breast carcinoma, we have stage 1 and stage 2A. What is this stage 1 and stage 2A? The permutations and combination of T and N gives us stage 1 and 2A. Usually, tumor of size less than 5 centimeter, T1 and T2, and N1 or 0 comes under stage 1 and 2A. These are called early breast carcinoma. The treatment for early breast carcinoma is surgical treatment, chemotherapy, and hormonal therapy. Under surgical treatment, we have conservative breast surgery, where we do wide local excision of the lump with 1 centimeter margin, conserving the remaining breast tissue, and we can do sentinel lymph node biopsy. If the axillary group of lymph nodes are involved on doing sentinel lymph node biopsy, we'll do axillary dissection or else we'll not do it. Following breast conservation surgery, radiotherapy is must to prevent the recurrence of the disease. If the patient has the tumor size more than 4 centimeter or the tumor is multicentric, we can't do conservative breast surgery. We should go on for mastectomy. Mastectomy, usually these days we do simple mastectomy or modified radical mastectomy. The radical mastectomy is outdated nowadays. We don't do it. Simple mastectomy is removal of breast tissue without axillary dissection. Modified radical mastectomy is removal of breast tissue. Along with that, we remove level 1, 2, 3 axillary group of lymph nodes. What is this level 1, 2, 3 axillary group of lymph nodes? The lymph nodes, group of lymph nodes lateral to pectoralis minor muscle is called level 1 group of lymph nodes. Posterior or deep to pectoralis minor muscle is called level 2 group of lymph nodes. Medial to pectoralis minor muscles is called level 3 group of lymph nodes. These 3 group of lymph nodes we remove in modified radical mastectomy. Along with removal of these 2 things, we have removal of pectoralis minor or not. If we remove pectoralis minor muscles, it is called as Patty's operation. If we don't remove, we just divide the pectoralis minor muscle, it's called as Scanlon's modified radical mastectomy. If pectoralis muscle is retained, only these 2 structures are removed, it is called as Auchincloss modified radical mastectomy. This Auchincloss modified operation is usually performed nowadays. So after performing surgery, we have chemotherapy. The CMF and CAF regimen is not used nowadays. That is methotrexate and 5-fluorouracil or cyclophosphamide, adriamycin, and the 5-fluorouracil is not used nowadays. Nowadays, we divide the patient into HER2 new positive and HER2 negative by immunohistopathological studies. If the patient has HER2 new negative disease, we give 4 cycles of AC, that is adriamycin and cyclophosphamide, or EC, that is epirubin and cyclophosphamide. Followed by that, we give 4 cycles of taxanes, that is paclitaxel. In HER2 new positive patients, we give 6 cycles of TCH, that is taxanes, carboplatin, and herceptin with pertuzumab. This herceptin and pertuzumab is anti-HER2 agents, HER2 new receptor agents. This about the chemotherapy. Then radiotherapy, I told it is must in case of breast carcinoma if we do breast conservative surgeries. Then we have hormonal therapy in ER and PR positive, ER/PR receptor positive patients. We can give tamoxifen, which is a selective estrogen receptor modulator, or we can give letrozole, which is an aromatase inhibitor. This is about the treatment of early breast cancer. Then we have the treatment of locally advanced breast carcinoma, where the TNM staging comes under this locally advanced breast carcinoma is TNM stage 2B and 3. The T can be tumor can be T3, T4A, T4B, and T4C. The nodal staging can be 1 or 2. It is again divided into operable tumor and inoperable tumor. Our operable tumor are 3A, where we have T3N1M0. In this locally advanced breast tumor, which are operable, the treatment is similar to early breast carcinoma. With that, we give mandatory chemotherapy and radiotherapy. In inoperable cases of locally advanced breast carcinoma, these are stage 3B and C. We give neoadjuvant chemotherapy to downsize the tumor, and then we perform surgery following that chemotherapy and radiotherapy. In stage 4, which is a metastatic breast carcinoma, we only give palliative hormonal therapy, or we can perform palliative surgery, that is simple mastectomy if the patient have ulceration, bleeding. We can give palliative radiotherapy, and if the patient have bone secondaries, we can give localized radiotherapy to treat this disease. This is about management of breast carcinoma. To summarize the management of breast carcinoma, under investigation, we have triple assessment, which is clinical examination, radiotherapy, and biopsy. The radiological examination, we have USG less than 40 years of age, mammography done more than 40 years of age. Biopsy, the most commonly performed one are incisional biopsy, that is core needle biopsy or true cut biopsy. And puncture biopsy we do in passage disease of nipple, and also we can do vacuum assisted biopsy. Immunohistochemistry study we'll do in case of biopsy. We get to know ER/PR positivity, HER2 positivity, and Ki-63 protein. If it is positive, we can see that by immunohistopathological studies. Then we have to check for metastasis. The investigation done are bone scan, abdominal USG, ultrasound, the chest X-ray, and PET-CT we only do in case of inflammatory breast carcinoma and locally advanced breast carcinoma. Then we saw the management treatment, where we have different treatment modalities for early breast carcinoma, locally advanced breast carcinoma, and metastatic breast carcinoma. In early breast carcinoma, we have surgery, that is breast conservative surgery. If the patient has tumor more than 4 centimeter and multicentric lesion, we perform either simple mastectomy and modified radical mastectomy. Following that, we give chemotherapy. In the HER2 new negative patients, we give 4 cycles of AC or EC followed by 4 cycles of T. And then in HER2 new positive patients, we give 6 cycles of TCH and with P, that is pertuzumab. And then we can give hormonal therapy in ER/PR positive patients, that is tamoxifen and letrozole. In locally advanced breast carcinoma, we have two types, that is operable and inoperable type. Inoperable type, the treatment is similar to early breast carcinoma with mandatory chemotherapy and radiotherapy. In inoperable case, we give neoadjuvant chemotherapy to downsize the tumor. Following that, we do perform surgery, chemotherapy, and radiotherapy. In metastatic breast carcinoma, that is stage 4 TNM, we give palliative hormonal therapy. We can do palliative surgery, palliative radiotherapy. In bone secondaries, we give localized radiotherapy. Thank you for listening.